Thank you. I would like to thank the organizers of this meeting for inviting me. I'm very grateful. So I would like to talk today about accelerated partial breast irradiation. So what is partial breast irradiation? It's very simply a reduction of the overall treatment time. So Dr. Castro talked about 3 weeks of radiation. Now I'm going to talk about only 1 week of radiation. So when you reduce the time to 5 days instead of 6 weeks or instead of 3 weeks, you've got to reduce the volume that we treat from whole breast into partial breast. And partial breast, as you see, it only includes the seroma or the tumor site initially, with a margin of 1.5 to 2 centimeters around. And once you do that, you can actually afford increasing the dose per fraction into 3.5 gray or 3.8 gray or even 4 or 5 gray dose per fraction. And you've got to reduce the total dose, otherwise the toxicity will be high. So partial breast irradiation, you reduce the volume, you reduce the overall treatment time, and you could increase the dose per fraction. So it is an intense treatment. So partial breast radiation is a natural progress in breast radiation oncology. Our colleagues, the surgeons, went through this phase, which is de-escalation of the treatment, moving from a radical mastectomy into simple mastectomy and now lumpectomy. So that's what they went through maybe 20 to 25 years ago. Radiation oncologists, it took long time to move from whole breast radiation into partial breast radiation, very simply because the technology was not there. Once the 3D planning was found or was described, the technology was present and we could look at the seroma inside the breast and target it in our treatment. So at this point, when we treat breast with radiation, we have probably 3 options. The standard option, which is standard 6 to 7 weeks of radiation with 2 gray per fraction. The second option will be hypofractionation, as was described by Dr. Castro. You could reduce the overall treatment time into 3 to 4 weeks, and we know that the Canadian and the British are pioneers also in this field. And now we can actually do the partial breast radiation, and we can finish the treatment in 1 week. And what's the rationale for partial breast radiation? A lot of people would be concerned, what if there was some tumor outside the quadrant and the risk of local failure might be higher? Basically, the data suggests that the majority of local failures in the breast come in the original site. It's almost 90% in some series, 80% in others. The advantage of partial breast radiation, you basically decrease the time, and it is basically convenient to patients. In the US, in some states, like in the Midwest, it is very difficult for the patient to drive long distance to go every day for radiation treatment for 6 weeks, and patients would prefer to have mastectomy instead. So partial breast radiation can actually solve this problem. There is an increase in the quality of life of patients once they finish their whole radiation in 1 week or even less. And it actually reduce the risk of toxicity too, because you are away from the lung and from the heart. So since partial breast radiation or accelerated partial breast radiation was described, there was an explosion of techniques. And I counted them, they vary between 20 and 25 different techniques. And you will see this all over. So we can divide them into 3 categories. The interstitial brachytherapy, which could include low dose rate or high dose rate. There is also the intracavitary, like the orthovoltage photon, the intrabeam, the target, the British system. There is also the Milan system using electrons intraoperative. And there is the American system using the marmocyte as brachytherapy. and external beam radiation, mostly the 3D conformal. There is IMRT, and there is also protons, like MD Anderson, Melinda, and Mass General. We use proton in partial breast irradiation. I will focus on those three categories, and we'll take one by one and describe it. But even within the intracavitary applicators, there are 5 or 6 different systems which you could use. So the question today in partial breast irradiation, which technique, which dose, which fractionation? Which technique should be used? So the technique which should be used should fulfill the following conditions as I see it. It has to be easy. It has to be simple. It has to be probably less invasive and applicable by most radiation oncologists, which means that if you have a technique that only large academic institutions can do, and the majority of the small or the community hospitals cannot do, this technique will not really be known, will not propagate. But the technique which will really dominate once partial breast radiation will be a standard of treatment sometime in the future should be simple and every radiation oncologist can do. It has to give less complications and good cosmetic results similar to whole breast radiation. And mostly today, we always look at the cost. It has to be less costly. It makes no sense to reduce the 6 weeks of radiation into 1 week and increase the cost. And it has to have same or better clinical results, or at least a non-inferiority. So let's take technique by technique. The first one is the interstitial brachytherapy. So here, the radiation oncologist will go to the OR with the surgeon during lumpectomy, and they will put catheters inside the breast, and they will have the lumpectomy cavity opened, and this is the way how it looks like. And you could use high dose rate or low dose rate. So this is the high dose rate. The patient will come twice a day for a whole week, and she will get connected to the high dose rate machine as illustrated in this figure. And there is good data about it. The overall local failure rate is quite low, probably similar to the whole breast irradiation, and there is more than 10 years follow-up data. So it is an acceptable technique that could be used. So what are the advantages and the disadvantages? It has been used the longest with the most extensive follow-up. The French used brachytherapy in breast for maybe 20 or 25 years. Also in the US, they used to use brachytherapy when they give a boost. So a lot of people have experience with it. It is conformal. It takes 4 to 5 days to finish, and it is well tolerated. However, it is an invasive procedure. There is a risk of infection, there is a risk of hematoma, there is also almost 30% risk of fat necrosis. You should have a formal training. It is not easy to do. There is a steep learning curve. So when you start to use brachytherapy, you're going to have the first maybe 10 or 15 cases that you will learn on. Maybe those cases might present with some complications. Just bear in mind that there is a heterogeneous dose distribution, and it requests hospitalization if it is low dose rate, and the long-term cosmesis still we need to wait for it. Now, what about the mammocyte, which has been used in the US very extensively? So it is a balloon that you could insert in the lumpectomy cavity, and the radioactive source will go inside. It's a high dose rate, as you see here. And those balloons might have different sizes based on the size of the breast. Since 2002, there have been more than 100,000 cases treated with mammocyte in the US. The results from the mammocyte are quite also good. We have 5 years follow-up results with quite acceptable local control and also cosmetic results. But the long-term data, we don't have it yet. So advantages of this technique: it has been used the most in the US, it is conformal, it takes 4 to 5 days, and it is well tolerated. But again, it is an invasive procedure. The risk of infection was quite high in the beginning, almost 16%, but most patients today, they receive prophylactic antibiotics, and this risk went down. It needs formal training. There is, again, a learning curve. We need to build up experience with it. And there is something called rate of explantation. So you pull the mammocyte, and then you realize that the patient probably had positive margins, so you have to take it out, or the mammocyte did not fit very well the seroma, and you have to take it out. The long-term cosmesis is not known yet. Now, what about the target, the British system, the intraoperative radiation? And this is simply an orthovoltage photons with 50 kV that this machine moves from one OR to the other, and it takes around 20 minutes to deliver the radiation. After the lumpectomy, you put the machine, you get the radiation, and it is a very attractive way for patients. They go to the OR, they sleep, they wake up with surgery and radiation done in one shot. So there is a large randomized trial coming from London. 17 centers participated. They accrued more than 1,000 patients. The arm 1 included a standard whole breast radiation, and arm 2 had partial breast radiation, and the dose they delivered was 5 gray at 1 centimeter difference, which a lot of people would think that this is a rather low dose. And they published their data in Lancet, showing at 5 years that there was no difference in local failure, whether you use 6 weeks of radiation or this one intraoperative radiation. The risk of local failure was 4% in both arms. However, they published an update, which was recently in Lancet Oncology, which showed rather very strange results, that the target arm had a significant increase in local failure with longer follow-up, but in the same time, mortality was increased in whole breast radiation in a way which the way how they explained it did not make sense to a lot of people. They claimed that cardiac death was increased in the whole breast radiation, and second cancer was also increased in the whole breast radiation. And the jury is out yet for Target, and I know a lot of centers use Target, but there are a lot of questions about the results of this study. Now we go to the Italian style, the intraoperative, what they call Elliott. So this is a linear accelerator, which also moves from one OR to the other. It's a bigger machine than Target, and it delivers electrons. And they did a phase 2 dose escalation to find out what is the optimal dose of treatment. And they decided that this dose is 21 gray in one shot. And again, a very attractive model. They had a large randomized trial, 50 gray plus 10 gray boost in one arm, and intraoperative radiation, 21 gray in one shot. They accrued 1,300 patients with a median follow-up of around 6 years. And the data came out very recently that the local failure in the intraoperative arm was 4.4% compared to 0.4% in the standard arm, which means that the local failure was almost 10 times more in the intraoperative arm, but still acceptable, it's 5%. And this is the graph reflecting the cumulative frequency of local failure, and on the right-hand side, the overall survival was the same. The advantages, it is conformal, it's one treatment, and there are large randomized trials. But the disadvantages, the radiation is delivered at the time of surgery. So you don't know whether the patient has positive lymph nodes or not, or LVI, or closed margin. So you might need to wait a week, for instance, to have this information, but the patient already received this intraoperative radiation. In fact, in both trials, once this situation occurred, that the patient is found to be ineligible for the trial based on the pathology results, patients would continue with the whole breast radiation after that, and they will consider this intraoperative radiation as a boost. It is technically difficult. You need to have a very good physics staff behind it, because if there is a mistake, this is only one shot. If it is delivered, you can't take it back, or you cannot compensate later for it. So the quality assurance is very important. And we basically don't know exactly what is the target here. When you have a cone of electrons going forward, what are you treating exactly? And maybe you don't treat enough. So that's probably some of the explanation for this high local failure rate, or higher local failure rate, although it's still acceptable. Now we come to the 3D conformal, using external radiation as a tool to deliver partial breast radiation. And there are, to my knowledge, 3 different techniques. The first technique, what I call the Frank-Vicini technique, is the one who described it, and it uses 4 to 5 non-coplanar fields directed towards the seroma, and the target will be the seroma plus around 2 to 2.5 centimeter margin. And the dose used in this technique is 38.5 gray in 10 treatments. This is a BID, or 3.85 gray per treatment. The second technique is the Silvia Formenti technique from NYU. And she always treats patients prone, as you see in this figure. And the patient is lying prone, and the radiation is delivered through 2 laterals, again, to the target, which includes the seroma and 1.5 to 2 centimeter margins. And she used a total dose of 30 gray in 6 gray per fraction over 2 weeks period. So it's a sort of like partial breast radiation, not as accelerated as the previous one. And the third technique is a technique described at Mass General. It also includes the seroma plus margin around it, and it's very simply a mini tangent. So you basically use, instead of standard tangents, you just close the field a little, and an on-fast electrons, similar to a boost technique. And these on-fast electrons should not exceed 20% of the dose, as illustrated in this figure. The doses we used at Mass General were included in a dose escalation study. Started with 32 gray in 8 fractions over 4 days, and going up to 36 gray in 9 fractions, and up to 40 gray in 10 fractions. We actually wanted to know, based on clinical data, what is the optimal dose to use in partial breast radiation. Because the 38.5 gray used by Frank Vicini, which is the dominant dose used now in partial breast radiation, is based on mathematical modeling and biological modeling, not clinical data. So we wanted to generate the clinical data. So as you see, by using external radiation, there is a wide variety of doses. So until today, we don't know what is the optimal dose. However, the dominant dose used is 38.5 gray. At Mass General, we continue to use 36 gray in 9 fraction as the standard dose for us. So the data so far is a little bit younger than the other 2 techniques, because 3D conformal started after the mammocide by a few years. But so far, the local failure rate is somehow very similar to whole breast radiation. Advantages, it is conformal, it is not an invasive technique, it takes 5 days, the dose is homogeneous, and it is less costly. Actually, the 3D conformal cost half the price of 6 weeks radiation, less than half the price of the mammocyte, and less than half the price of the interstitial implant. So it is the lowest in cost. What are the disadvantages? We are still looking for the optimal dose, the optimal fractionation. There is an issue with the patient setup. Once you treat part of the breast, if the patient moves a little during treatment, there is an error here. So there should be some image guidance which should go hand in hand with the partial breast radiation. The breathing movement, we looked at it and we studied. For some reasons, women breathe very slow, very shallow during the radiation. The maximum movement we saw was 0.5 centimeter. So we are not worried about the breathing movement. The tolerance of the non-target breast tissue and the long-term cosmesis is still something that we have to wait a few years. So the interesting thing is that when we have a paradigm shift, similar to moving from mastectomy into breast-conserving surgery, one randomized trial is not enough. And we had, maybe 20 years ago, 6 randomized trials, which totaled around 4,000 patients. And people moved from the mastectomy era into the conservative era, which was a very big jump. Then moving from the standard 6 weeks radiation with hypofractionation, there are 3 trials, probably more are coming, which are totaling around 3,500 patients. But the interesting thing, now we are moving from whole breast radiation into partial breast radiation as a whole paradigm shift. There are 9 randomized trials, which are totaling until today 14,000 patients. So once we have the data from this 9 randomized trial, if they are positive, partial breast radiation will be the standard of treatment. And those are the trials. Some of them include only 1 technique, and others include in the same time 3 techniques. We'll come into this in a second. So the first randomized trial assessing 3D conformal is a Canadian trial. And they included low-risk patients, like no positive lymph nodes. For instance, they accrued more than 2,000 patients, and they completed accrual in July 2011. And there was a communication at ASTRO 2 years ago with the cosmetic results. And this communication is not published yet. And in this Canadian study, they had a blind assessment of the cosmetic results, and they found that cosmesis is lower in the partial breast radiation than the whole breast radiation. Is the rate of fair or poor cosmetic results was 32% versus 19% in the whole breast radiation, whether assessed by a panel of nurses who were blind to the treatment arm or assessed by a panel of 3 physicians looking at pictures, also blind to the treatment arm. So it's clear that there is more fibrosis in the partial breast radiation as used in the Canadian study. They concluded that accelerated partial breast radiation was associated with some adverse cosmetic outcome at 3 and 5 years. And this is something we have to be careful. It was accompanied by an increase in grade 1 and grade 2 toxicity, but grade 3 was very little in both arms. And they tried to understand or to give an explanation why this partial breast radiation gave more fibrosis, probably because in the standard arm, the majority of patients did not use boost. And as you know, the Canadian hypofractionation is 3 weeks of treatment without a boost. There is a limited conformality in the APBI arm. Maybe they treated a larger volume than they expected. There is, or maybe the 6 hours in between these 2 treatments per day was not enough for a good, adequate repair time, or what they called asymmetric nature of partial breast radiation. If you treat one part of the breast with intense radiation and there is fibrosis, and the rest of the breast will be soft without complication, so there could be some pulling of the skin, which can cause some worse results. So that's the Canadian study. The paper is not out yet, so we're still looking at the paper, and I hope they will give an analysis, a dosimetric analysis on why these cosmetic results are not as good. Now, the largest randomized trial in partial breast radiation is the NSABP B39, also called RTOG 0413. This trial includes patients, half of them randomized to a standard 6 weeks of radiation, 50 gray plus 10 gray boost, and the other half, they were randomized to partial breast radiation using 3 different techniques. One is interstitial brachytherapy, as I described it a few minutes ago. The other one is mammocide, and the third one is 3D conformal. The investigator would choose which technique he or she will use, and they will send their dosimetric plan to the headquarters of NSABP to approve it, at least for the first 5 patients, and then they will go on their own after that. So that is a very good quality assurance. But the interesting thing, and this is the only randomized trial, which included rather higher risk patients. Everybody, when they started partial breast radiation, including our team, we were very careful to include only T1 and 0, the very low risk. But in the NSABP, they went up into a 3 centimeter tumor. They included also node positive, 1 to 3 node positive. The definition of margins or negative margins were no tumor on ink. They included young women more than 18 years old, while the majority of trials included only postmenopausal. They also included invasive lobular carcinoma and DCIS grade 1 and 2 and 3. So they included a rather higher risk patients in their trial. They started back in 2005, completed more than 4,000 patients in 2003. There is no results yet. And by talking with Frank Vicini, the PI, the first analysis might be done at the end of 2015 or 2016. And I think the results from this trial will set up the standard of treatment. If indeed both arms will give the same results, partial breast radiation might be a standard of treatment. Or if the partial breast radiation will have a higher local failure rate, a significant higher local failure rate, I think this will probably kill this whole field. And the interesting thing is that 70% of patients were treated with 3D conformal, and 23% with mammocide, and only 6% with implant, suggesting that the great majority of physicians or radiation oncologists would feel more comfortable with this 3D conformal than the other invasive techniques. The toxicity, they did some preliminary analysis, were very acceptable. And they looked at 1,400 patients who had 3D conformal toxicity, grade 2 less than 13%, grade 3 then less than 3%. So far, the toxicity is not really bad. So when you look at partial breast radiation in general, you've got to have a very delicate balance between the total dose you're going to use. At this point, there are a lot of different doses in the literature, starting from 32 gray into 42 gray. You've got to be careful with the dose per fraction, 3.4 up to 4.2 gray. Those are the doses used in the literature. And also we have to be careful with the volume you treat. You want to increase your total dose, you've got to reduce your volume you treat. The same thing with the dose per fraction. If you want to increase your dose per fraction, reduce your total dose and reduce the volume you treat. That's the balance that we have to find. What is this balance? And that's the goal of all these studies I described. So let me present some of the studies we have done at Mass General Hospital. So this is the dose escalation, starting with 32 and moving up to 40 gray, with 100 patients in each arm, a little bit higher in the 40 gray. And we found that the rate of moderate fibrosis was rather high at the 40 gray level and was acceptable at the 36 gray level and similar in the 32 gray level. So we think that 40 gray in 10 fraction is a little bit the ceiling for the partial breast radiation. That's too high. So whether it's 38.5 as used by the NSABP B39 or 36 in 9 fractions as used at Mass General, probably they are very close and very similar. And since we analyze this data, the standard PBI dose we use in our department is 36 gray in 9 fractions. However, 38.5 in 10 fraction is also acceptable. So some tips about partial breast radiation. We usually contour the seroma and we ask the surgeon to put 4 to 6 clips. If we don't have these clips, it will be very difficult to target our radiation to the seroma. And our surgeons were very cooperative with that, and this really helped facilitating moving with this program. We give a 1.5 to 2 centimeter margin around the seroma, and we have some rules of thumb until we analyze the data. The ratio of PTV, and PTV included the seroma plus 1.5 to 2 centimeter margin. So the volume of this PTV over the volume of the whole breast should not exceed 20%, which means only 1/5 of the breast should receive this high dose, this intense dose in partial breast radiation. Now, the Canadian study allowed up till 30%. The NSABP is allowing up till 30%. So here, I'm playing a little bit with the volume. I'm reducing the volume to compensate for this high dose per fraction in PBI. The non-target breast volume, so the volume of the breast, which is outside the PTV, 50% of this volume should not receive more than 50% of the dose. This is another rule of thumb that we followed, and we will analyze it when the data is mature. And we prescribe our dose on the 95% isodose line, and we have a technique, image guidance, to make sure that the patient is in the right setup. We call it Vision RT, and we also put some constraints based on data about the lung volume. We don't allow more than 3% in V20 gray. So 20 gray should only go to less than 3%. And we respect that very much. So what did the Astral do? They went and put a panel of experts to decide which patient should have partial breast radiation of protocol. And they divided these guidelines into 3 groups. What the Astro called suitable group, and the European did the same, and they called it low-risk group. Not exactly the same, but a little similar. So the suitable group is the postmenopausal patient, maybe 60 years old, T1 and 0, margins are negative, at least 2 millimeter, ERPR positive, so the real low-risk patients. That a lot of us really believe that many of them probably even don't need radiation. So there's a suitable group which you could do partial breast radiation in a very comfortable way. The same thing were done by the European. Then we have the cautionary group, and the Astro put cautionary because at that time there was not enough data. Something like DCIS was in the cautionary group, but since the Astro guidelines were published, there are more and more data which came out on DCIS, grade 1 and 2, which suggests that the risk of local failure is very acceptable. Or if the tumor is between 2 and 3 centimeters, and other factors as described here. And then we have the unsuitable group. You cannot do PBI after neoadjuvant chemotherapy. You cannot do PBI for T3 or for T4 or for node positive at least, until the NSABP trial is published. So in conclusion, accelerated partial breast radiation is an emerging radiation technique in breast cancer. The short-term follow-up results from all these randomized trials, PBI versus whole breast radiation, for highly selected early-stage breast cancer patients suggest a slight increase in local failure rate, mostly coming from the intraoperative techniques. The early cosmetic data suggests also an increase in fibrosis or toxicity, so we have to be careful with the technique we use. The long-term follow-up is needed to ensure that PBI provides the same overall survival and local control rate as whole breast radiation. And phase 3 randomized trial data showing PBI to be a safe and well-tolerated treatment, but longer-term follow-up is required. So the remaining questions in these fields are as follows. Basically, a lot of groups, American or European, like the American Society of Breast Surgeons and other groups, they provided guidelines for people who want to use PBI of a protocol. The ASTRO and ESTRO, also consensus panel, also provided guidelines too. We need to wait for the mature phase 3 trials, mostly the NSABP and also the Canadian trial and other trials to be published with the long-term follow-up. And this will be around 2015 to 2020, so we have a few years to wait. And we need more studies for optimal dose and fractionation and technique. Thank you for your attention.